everyone. I'll be talking on utility of preoperative CT angiogram in planning of free fibula flaps primarily. So how many of you have used Google Maps to get here today? Everyone? Nearly? Okay. And despite living in Calcutta for several months and years, how many of you will continue using Google Maps? Okay. So it's always good to know where we are headed, what we are looking for, and whether there's a mocha happening out on the street leading to a jam or a block, no matter how many times you travel that road. So luckily we work in an institute where most of the mandibular maxillar reconstructions are done in a planned manner, and we get an opportunity to assess the patients preoperatively in the OPD. Now, we have a waiting period of a few days during which we assess the patients and plan what kind of a reconstruction would be best for them. So we get an opportunity to assess them for peripheral vascular diseases, any skin changes, arthritis, etc. because these patients are of a certain age group. So is it worthwhile paying attention to the donor site of a Osseocutaneous flap during pre-op planning stage? You're subjecting the patient to extra contrast, extra radiation, extra 3,000 rupees, extra 4,000 rupees, another trip to the radiology department. Is it really worth it? There is enough literature published indicating case reports where surgical complications, as Adisha mentioned yesterday, undesirable, unexpected outcome leading to a delay in patient recovery have occurred. Preoperative interventions far outweigh post-operative salvage from the point of view of patient safety and medical liability. During a preoperative vascular clinical evaluation, it is imperative to recognize that the clinical examination may lead to an unjustified sense of security. Even normal palpable pulses and audible Doppler signals cannot guarantee the presence of a sufficient blood supply in the lower limb. The patient cohort that we get, they more or less have these common comorbid conditions, as a result of which we as microvascular surgeons tend to have blinkers on. We don't think that a 65-year-old, 68-year-old hypertensive, dyslipidemic guy is at a high risk for peripheral arterial disease as well. It has been published that peripheral arterial disease is one of the most underdiagnosed and undertreated vascular diseases despite its significance burden in India. Almost 30% of the Indian population suffers from it. And it has the equivalent risk factor of cardiovascular events as coronary artery disease. Alongside, we also come across during fibula flap harvest certain vascular anomalies of embryology and development as outlined by Kim et al. There are 10 different types of vascular anomalies that can be encountered during this flap harvest. So based on a systematic review of 5,790 limbs, Abu Faul and Bormundi found that critical infrapopliteal vascular anomalies are present in 10% of the population, with the predominance of the peroneal artery, 5.2%. The group from TMH recently published their data of 3 years, Jan 18 to May 21, where over 714 fibula flap harvest patients were analyzed, and 3.6% had certain type of variations. And 4 of these patients had peronia magna over a period of 3 years. Although they successfully managed to get away with limb salvage and all flaps recovered, however, intraoperatively, as a reconstructive surgeon, when you're hit with this surprise, you have to know how to deal with it. This is another study which is published from Dehradun indicating the distribution of popliteal variation and anatomical variation in North Indian population, which also shows 4% predominance of type 3 vascular anomalies. So in our institute, over the last 8 years, 8 patients have had some different kind of vascular anomaly which has been identified intra-op on table. This has led to a certain compromise where we've had to compromise the vessel length, or we've had to compromise the bone stock that we have taken, or we've had to take a vein graft and revascularize the limb. These can be mitigated by a preoperative radiological evaluation. Now, whether to do a CT angiogram or a color duplex ultrasound, there are many modalities available. CT angiogram, yes, is invasive with radiation and contrast exposure, but it is more accurate. It gives more details on the course of the septocutaneous and periosteal perforators. And since also now many patients go for primary dental implants, we can do a bone stock assessment, the characterization of the osteoporosis, the degree of the bone medullary cavity cortical ratio thickness. The duplex ultrasound is, yes, cost effective, bedside, non-invasive, but it is operator dependent and difficult in obese patients with stiff calcified vessel walls. Additionally, with the CT angiogram now CAD-CAM technology being used, it is beneficial. Other modalities like MR angiogram and digital subtraction angiography are also described but not commonly used. So in our institute, at least this year, 13 patients have undergone preoperative radiological evaluation of their lower limbs, and this is the data chart of the 13 patients who were evaluated, and as you can see, several of them have had knee replacements, osteoarthritis, hypertension, and in fact, severe atherosclerotic diseases have also been found, leading to change of intra plan, change of flap plan, and successful limb salvage outcome. Further analysis is required so that we can develop a protocol to assess the patients preoperatively on what their leg claudication symptoms are, since 50% of the peripheral arterial disease patients are undiagnosed. All these steps are necessary since we should not trivialize fibula flap harvest. Doing it routinely does not mean that there is not a danger or a morbidity associated with it. To conclude, routine preoperative angiogram of the lower extremity for all patients being evaluated for free fibula flap is important to ensure safety and success of the procedure. Physical examination alone is insufficient to detect vascular anomalies, which may result in documented limb and flap compromise. Thank you.